Good afternoon to everybody. My name is Veronica Salvatore and I work in Bologna in Policlinico Sant'Orsola Malpighi. I would like to speak with you about the use of US in the emergency department during the COVID-19 outbreak and about our experience. COVID is a new challenge for medical doctors as we just learned about it in the last 2 months. Concerning US, we were used to perform lung US in respiratory failure, but not in a routine setting. To summarize our experience, I would like to focalize on the step that we lived. The curiosity of the moment, it is real, the relatively huge wave of patients that came to our attention, and lastly today, after 1 month of quarantine, and the changes that we have been through. At first, we were surprised to discover that US was a perfect tool for the evaluation of COVID pneumonia, mostly in its peripheral presentation. It is worth to remind you that at first we used a CT scan to confirm our findings. Every day was a discovery, and as we learned about the most common presentation, we have changed the approach to the patient. In particular, less stretchers, more chairs in our rooms in order to examine the patient seated and not supine. Moreover, we understood that stethoscope was less useful, and that it was quite abandoned, substituting it with the probe, as happens in the abdomen in my experience, but it is another story. Surprisingly, these steps corroborated our confidence with the technique, and we were thrilled. But at first, not all our colleagues were skilled enough with lung US. So we have organized a training session, because cooperation is fundamental on every context, even more in the emergency department. But after a while, the scenario changed. Many more patients came to our attention, leaving us less time to take care of them. Patient management included CT scan only in case of clinical radiological discrepancy, that is an elevated alveolar arterial difference, that is, in our opinion, the best parameter at arterial blood gas in imaging negative patients at X-ray and US. This means that US is performed in quite all patients, except all patients that cannot be well mobilized, and it allows the allocation in COVID wards in case of interstitial syndrome with COVID characteristics. Now, after 1 month of quarantine in Italy, local health policy has been changed. Critical patients are decreasing in number, and a lot of patients come to our attention looking for treatment. Except for patients from nursing homes, that are more and more, less high priority codes and more low priority codes are coming. Thus, a fast track has been implemented. Patients with 1 or more COVID-related symptoms and respiratory frequency below 18 per minute and oxygen saturation above 95% are submitted to perform an electrocardiography, arterial blood gas, and a sit stand-up test to evaluate if the saturation more than 4% occurs. In the second room, an emergency department doctor performs lung US examination, and lastly, an infectious disease specialist evaluates the whole condition. We are using the LUS score to standardize our practice, which is a score that ranges from 0 to 36, dividing lung parenchyma in 12 areas. 0 is given in presence of A pattern, whereas 1 in case of B lines occurring in less than 50% of the intercostal space, 2 points in the presence of the so-called wide lung, and 3 points in the presence of consolidation. Moreover, we report P when pleural thickness or irregularity are evident. Here I present you some images of some patient. In this case, you can see a thickness of the pleural line and a 1 point pattern with B lines occurring in less than 50% of the intercostal space. Also in this case, only few B lines. In this case, you can see the thickness of the pleural line with a little consolidation in the upper part and a 2-point image. Or in this case, we can see a white lung pattern. About 20% of our patient goes out from the fast track and follow the conventional way, which includes complete lab exam, X-ray and/or CT scan, and the patient is eventually hospitalized. Another issue that I would like to discuss with you is the critical patient, because all patients with dyspnea are considered COVID affected until proven wrong. However, many other causes of respiratory failure must be kept in mind, such as pulmonary edema, COPD reacutization, or pulmonary thromboembolism, for example. Furthermore, those patients can be submitted only to backside X-ray and not to CT scan for the unstable condition. In this context, lung US is extremely useful. The evidence of bilateral patchy B pattern with spared areas allows to suspect viral pneumonia. Lastly, one of the main challenges now for the emergency department doctor is discriminating between COVID and no COVID patients in order to allocate them in the correct ward. For example, urinary fever or many other conditions such as confusion raise the suspect of COVID infection. Can I consider COVID-free a patient with fever if another condition might explain it? Neither CT scan can be performed in all patients nor swabs. In addition, the delay between a swab and its result exposes the patient to a possible intra-hospital COVID infection from other patients in the same room. For such reason, lung US is very useful to screen a possible and early COVID-related pulmonary involvement. I hope to have transmitted to you our enthusiasm in using lung US in the emergency department during COVID pandemic, and not only. Thank you for the attention.